Hi, class. In this lecture, we will be discussing matters related to dissociative disorders, anxiety disorders, and somatic symptom disorders to include their clinical presentation, epidemiology, comorbidity, etiology, and treatment options. Let's get started. So, dissociative disorders are a group of disorders characterized by symptoms of disruption and or discontinuity in consciousness, memory, identity, emotion, body representation, perception, motor control, and behavior. And these symptoms are likely to appear following a significant stressor or years of ongoing stress, such as abuse. Now, stress can be interpreted in a number of different ways, but when we talk about dissociative symptoms, we're really talking about stress more in the context of traumatic stressors. Now, occasionally, one may experience temporary dissociative symptoms due to a lack of sleep or ingestion of a substance. However, these would not qualify as a dissociative disorder due to the lack of impairment in functioning. Furthermore, individuals who suffer from acute stress disorder and PTSD often experience dissociative symptoms such as amnesia, numbing, flashbacks, and depersonalization or derealization. However, because of the identifiable stressor and lack of additional symptoms that we're going to be discussing, they meet diagnostic criteria for a stress disorder as opposed to a dissociative disorder. So, the key diagnostic criteria for a dissociative identity disorder is the presence of two or more distinct personality states or an experience of possession, which is referred to as criteria A. Now, how overt or covert the personality state is depends on psychological motivation, stress level, cultural context, and emotional resilience, as well as internal conflicts and dynamics. And severe or prolonged stress may result in sustained periods of identity confusion or alteration. Now, those presenting as being possessed by spirits or demons, and for a small proportion of non possession form cases, the alternate identifies as readily observable. So those identities are presented in a way that it's as if they take over the person's personality for that period of time. Now, generally, though, the identities in non possession form dissociative identity disorder are not overtly displayed or are only subtly displayed when they are. It is just in a minority of individuals and where it manifests as different names, hairstyles, handwritings, wardrobes, accents, etc. And if the alternate identities are not observable, their presence is identified through sudden alterations or discontinuities in the individual's sense of self, sense of agency, as well as recurrent dissociative amnesias. And so, really, what we're talking about here when we talk about dissociative identity disorder and criteria A is we're talking about what used to be referred to as multiple personality disorder, right? So, when we're speaking about this, the idea is not, in the possession form, is not that the person is actually possessed, but that maybe due to certain, culturally mediated constructs, like the idea of possession, that the person's personality fragments as a result of some sort of ongoing and repetitive traumatic experience. Now, the second main diagnostic criteria, criteria B for dissociative identity disorder, is that there must be a gap in the recall of events or the information or the trauma due to switching personalities. Now, these gaps are more excessive than typical forgetting one may experience due to a lack of attention. The dissociative amnesia presents as gaps in autobiographical memory or lapses in memory of well learned skills or recent events, and discovering possessions for which there is no recollection of ever owning, and can involve everyday events and not just events that are stressful and traumatic. Now, it should be noted that most possession states occurring around the world are part of a broadly accepted cultural or religious practice and usually should not be diagnosed as dissociative identity disorder, which would be referred to as criteria D, right? So that it's not listed on this slide, but you'd have a criteria D where if it's exclusively resulting from the religious ritual or religious context, you wouldn't necessarily diagnose. Um, Even though the idea of somebody kind of manifesting as being possessed by a spirit, for example, or believing that they are possessed by a spirit, could be something that's culturally mediated in the sense that they become aware on some level, consciously or unconsciously, that this concept of being possessed by a spirit or a demon or something like that exists. And therefore, in their dissociative state, they play that out, right? You can think of this as kind of similar to a form of psychosis, but it's not exactly the same. The possession form identities in dissociative identity disorder manifest most often as a spirit or a supernatural being taking control and the individual speaking or acting in a distinctly different way. And these identities present recurrently and are involuntarily and unwanted and cause significant distress or impairment, which relates back to criteria C. Impairment varies in adults from minimal, such as high functioning professionals, to profound, where it's extreme and really negatively affects the person's life. For those minimally affected, marital, family, relational, and parenting functions are more likely to be impaired by symptoms of dissociative identity disorder rather than their occupational and professional lives. Now, while personalities can present at any time, there is generally a dominant or primary personality that is present most of the time. From there, an individual might have several subpersonalities, although it's hard to identify how many subpersonalities an individual might have at one time. And it's believed that there are, on average, 15 subpersonalities for women and 8 for men. Now, the switching or shifting between personalities varies among individuals and can range from merely appearing to fall asleep to very dramatic presentations involving excessive bodily movements, though for most, the change is subtle and may occur with only subtle changes in overt presentation. So, when sudden and unexpected switching is generally precipitated by a significant stressor, as the subpersonality best equipped to handle the current stressor will present. And so this is an important one to keep in mind here that the presentation of these various personalities can be thought of as a fragmenting of one's consciousness to deal with a traumatic stressor. In essence, if the unconscious could speak, it might say something like, my personality cannot handle the trauma that is happening to me at this moment. So I'm going to formulate a personality that can, that is both part of me and is an other. And if this happens as a defensive strategy enough, then the person might fragment into different personality presentations. Now, do these personalities know that each other exists? Well, the relationship between subpersonalities varies between individuals, with some personalities, some individuals reporting knowledge of other subpersonalities, while others have a one-way amnesic relationship with subpersonalities, meaning they are not aware of other personalities. And these individuals will experience episodes of amnesia when the primary personality is not present. And so, the amnesia piece is a really good indicator that the person is kind of defensively fragmenting their personality as a means of kind of psychological survival. Now, dissociative amnesia is identified by the inability to recall important autobiographical information, and it's usually of a traumatic or stressful nature. It often consists of selective amnesia for a specific event or events, or generalized amnesia for identity and life history. This type of amnesia is different from what one would consider permanent amnesia in that the information was successfully stored in memory but cannot freely be recollected. And so it's conceptualized as possibly being a reversible memory retrieval deficit, meaning that you could uncover those memories. But individuals experiencing permanent amnesia often have a neurobiological cause, whereas dissociative amnesia often does not. It has a psychological cause, right? So when there's a neurobiological cause, there may actually be brain damage that's occurred that prevents the person from accessing their memory content. Whereas with dissociative amnesia, it's usually that same kind of fragmenting or repressive act to push um, uh, to push information outside of awareness, right? And it's done reflexively, it's done unconsciously. Hence it being repressive in nature. Whereas a willful pushing something outside of one's awareness or avoiding something or evading something would be suppressive in nature. Now, there are a few types of amnesia within dissociative amnesia. There's localized amnesia, which is the most common type. And this is the inability to recall events during a specific period. Now, it's important to note that when we talk about dissociative amnesia, it doesn't just occur within dissociative identity disorder. Dissociative amnesia can occur with other types of traumatic stressors, and it can be superimposed on other disorders because you're literally repressing information or repressing memories of a traumatic context to defend the self. Now, dissociative identity disorder can be an extreme manifestation of this, but you might see this as occurring in other contexts as well. Now, there are very few types of amnesia with dissociative amnesia, like I said. Like I said, there's also that localized amnesia, which is the most common type. The length of time within a localized amnesia episode can vary. It can be as short as the time immediately surrounding the traumatic event to months or years should the traumatic event occur that long. And that's commonly seen in abuse and combat situations or hostage situations where people are held captive or experience ongoing and repetitive assault and trauma. Selective amnesia is the next type of dissociative amnesia. And this is, in a sense, a component of localized amnesia in that the individual can recall some, but not all of the details during a specific period. For example, a soldier may experience dissociative amnesia during the time that they were deployed, yet still have some memories of positive experiences, such as celebrating Thanksgiving or Christmas dinner with members of their unit. There's also systematized amnesia, which occurs when an individual fails to recall a specific category of information, such as not recalling a specific room in their childhood home where maybe trauma occurred, for example. Conversely, some individuals experience generalized dissociative amnesia, in which they have a complete loss of memory for most or all of their life history, including their own identity, previous knowledge about the world, and or well-learned skills. Individuals who experience this amnesia experience deficits in both semantic and procedural knowledge. This means that individuals have no common knowledge, so they can't identify letters, colors, numbers, nor can they engage in learned skills, such as, let's say, typing or tying their shoes or driving a car. Um, while generalized dissociative amnesia is extremely rare, it is also extremely frightening. The onset is acute, and the individual is often found wandering in a state of disorientation. Many times, these individuals are brought into emergency rooms by law enforcement following a dangerous situation, such as an individual wandering in a busy road. The distress and impairment suffered by those with dissociative amnesia resulting from childhood or adolescent traumatization varies. Some are chronically impaired in their ability to form and sustain satisfactory attachments, while others are highly successful in their occupation due to compulsive overwork. And finally, a substantial subgroup of those affected by generalized dissociative amnesia develop a highly impairing, chronic, autobiographical memory deficit that's not ameliorated by returning their life history, resulting in poor overall functioning in most of life's domains. Now, depersonalization and derealization disorder is another disorder within the dissociative disorders category. And this is categorized by recurrent episodes of depersonalization and or derealization. Depersonalization can be defined as a feeling of unreality or detachment from oneself. Individuals describe this feeling as an out of body experience where you are an observer of your thoughts, feelings, and physical being. Furthermore, some patients report feeling as though they lack speech or motor control, thus feeling at times like a robot, disconnected from their bodies. Distortions of one's physical body have also been reported, with various body parts appearing enlarged or shrunken to them. Emotionally, one may feel detached from their feelings, lacking the ability to feel emotions despite knowledge that they have them. And symptoms of derealization include feelings of unreality or detachment from the world, whether it be individuals, objects, or their surroundings. For example, an individual may feel as though they are unfamiliar with surroundings, even though they are in a place they have been many times before. Now, feeling emotionally disconnected from close friends or family members whom they have a strong feeling for or feelings for is another common symptom experienced during derealization episodes. And sensory changes have also been reported, such as feeling as though your environment is distorted, blurry, or even artificial. There's also distortions of time, of distance, size, and shape of objects that might occur. And these episodes can last anywhere from a few hours to days, weeks, or even months. The onset is generally sudden and, like the other dissociative disorders, is often triggered by intense stress or trauma. Now, many individuals describe feeling like they're crazy or are going crazy and fear they have irreversible brain damage. They experience an altered sense of time and may be obsessed about whether they really exist. Um, Now, as one can imagine, depersonalization and derealization disorder can cause significant emotional distress, as well as impairment in one's daily functioning. The disorder is associated with major morbidity, and impairment occurs in both interpersonal and occupational spheres due to, quote, the hypo emotionality with others, subjective difficulty in focusing and retaining information, and a general sense of disconnectedness from life. And that is a quote directly from the DSM. So, when we talk about the epidemiology of dissociative disorders were once believed to be extremely rare. However, more recent research suggests that they may be more present in the general population than once thought. Estimates for the prevalence of dissociative identity disorder, so that disorder that used to be called multiple personality disorder, in the US, in adult populations is 1.5%. It's a very large percentage when you consider the population of the United States. And this is with women predominating in adult clinical settings, which may have to do with trauma profiles. But symptom profiles, clinical history, and childhood trauma history show few gender differences, though women have higher rates of somatization. Research shows that dissociative amnesia, so the kind of dissociative state where you are repressing memories, occurs in approximately 1.8% of the US population. It's estimated that about one half of all adults have experienced at least one episode of depersonalization or derealization during their lifetime. However, symptomatology that meets full criteria for the disorder is markedly less than these transient symptoms. So thinking about that, that may shock you to hear, Oh, wow. About one half of all adults in the US have experienced at least one episode of this, but think about it. If you've ever had an experience where time seems to slow down, or you almost have a disconnected experience when something traumatic is happening, think about if you've ever had, a child that falls out of their height chair, and time slows down, or if you've ever been in a car accident and it seemed like time slowed down ahead of the impact, or you can't remember the impact happening. That can be an example of how this might play out, but not necessarily meet diagnostic criteria. Now, a 1 month prevalence of about 1 to 2% was reported in the United Kingdom, and the onset of dissociative disorders is generally late adolescence to early adulthood, with the exception of dissociative identity disorder. Now, that's something that you've probably heard me say before in these lectures, and will hear me say again. The onset is generally late adolescence and early adulthood. Why is that? Well, as I may have mentioned already in the course, the reason for that often is that the dorsolateral prefrontal cortex of the brain and the frontal lobes of the brain are finalizing their development in late adolescence to early adulthood. So you often see biologically based or genetically based disorders begin to manifest as this final stage of development of the frontal lobes is occurring. So usually that's between around 18 or 19 years old and 26 years old. So due to the high comorbidity between child abuse and dissociative identity disorder, it's believed that symptoms begin in early childhood following the repeated exposure to abuse. However, the full onset of the disorder is not observed or noticed by others until adolescence. So, given that given that a traumatic experience often precipitates dissociative disorders, um, just correcting a spelling error there. Um, Given that there is this kind of traumatic relationship, it should not be surprising that there is high comorbidity between most dissociative disorders and PTSD. Um, that being said, comorbidity of depersonalization and derealization disorder with PTSD is actually low. Similarly, depressive disorders are also commonly found in combination with dissociative disorders, likely due to the impact the disorders have on social and emotional functioning. In individuals with dissociative amnesia, a wide range of emotions related to their inability to recall memories during the episode often present once the amnesia episode is in remission. These emotions frequently contribute to the development of a depressive episode. And there's been some evidence of comorbid somatic symptom disorder and conversion disorder, particularly for those who experience dissociative amnesia. Furthermore, dependent, obsessive compulsive, avoidant, and borderline personality traits and disorders are comorbid for dissociative identity disorder and dissociative amnesia. And there's evidence of comorbid substance related and feeding and eating disorders. Anxiety disorders are also common for depersonalization and derealization disorder, and often individuals concurrently have unipolar depressive disorder, which is distinguished from bipolar depression as just being either major depression or kind of within the persistent depressive disorder sphere, the dysthymic disorder, etc. Um, Now, why would this be the case, right? Especially the fact that there is this low correlation or relationship between depersonalization disorder and PTSD. Well, the common thread is that there is a relationship, it appears, between trauma and dissociation, right? Regardless of its presentation, right? So I think that's a really important one to keep in mind. Um, Now, why is depersonalization, derealization disorder um, not correlating highly with PTSD? Well, that may have a lot to do with the somewhat limited framework of PTSD's diagnostic criteria, right? Where PTSD doesn't represent reactions to all trauma. PTSD is a specific disorder that is based on trauma. And keep in mind, there has to be that real and perceived threat to one's life in PTSD. And so that may have a lot to do with it there. But across the board, one thing that we can see is that there is a relationship between trauma and dissociation. Why? Because dissociation can be thought of as a form of repression, right? It's a defense, psychological defense. So when we think about this, that kind of lends us to a discussion of the etiology of dissociative disorders. So, breaking this down from a biological perspective, when studies on the involvement of genetic underpinnings are looked at, they need there needs to be additional research. That's one thing that is clear. However, there's some suggestion by the research that does exist that heritability rates for dissociation range from between 50 to 60%, which is an interesting one. However, it is suggested that the combination of genetic and environmental factors may play a larger role in the development of dissociative disorders than genetics alone, right? So again, something that you've no doubt seen already, and you will continue to see through the remainder of the lectures for this course, is that for most presentations of psychological disorders, there is a gene by environment interaction. There's a relationship between the genetics that exist for the person and a specific type of reaction. There's also epigenetic considerations, right? If one might theorize, for example, that if there is a repetitive trauma history within a family, you may see multiple people dissociating to deal with that trauma. And or if people are in traumatic environments, let's say they live in a war-torn area like, in the Middle East, in Syria, or in Israel or Palestine, you might see situations where the nature of living in a certain context may result in certain presentations of trauma, right? And so, in that kind of circumstance, the reactions to trauma could appear to run in families and they might appear genetic, but in reality, it's environmentally based. But there's a whole cohort of individuals that are genetically related to each other that are having these kinds of experiences because of their broader context. So that's something to keep in mind as well. Now, there's also cognitive theories of dissociation and dissociative disorders. So, one proposed cognitive theory of dissociative disorders, particularly dissociative amnesia, is a memory retrieval deficit. More specifically, Kopelman in 2000 theorizes that the combination of psychological stress and various other biopsychosocial predispositions affects the frontal lobe's executive system's ability to retrieve autobiographical memories. Neuroimaging studies have supported this theory by showing deficits to several prefrontal regions of the brain, which is one area that's responsible for memory retrieval. Now, despite these findings, there's still some debate over which specific brain regions within the executive system are responsible for the retrieval of or for retrieval difficulties, as research studies have reported mixed findings. So, specific to dissociative identity disorder, neuroimaging studies have shown differences in hippocampus activation between subpersonalities. So, as you may recall, the hippocampus is responsible for storing information from short term to long term memory. It's hypothesized that this brain region is responsible for the generation of dissociative states and amnesia. So, essentially, there are different neuroimaging results based on the presentation of subpersonalities, based on how much the memory centers of the brain are active or are maybe tamping down on recall, which would be expected if you have a repressive process going on. But also, as alluded to, there are sociocultural considerations to think about as well. And the sociocultural model of dissociative disorders has been primarily influenced by Lilienfeld and colleagues in their 1999 study, who argue that influence of mass media and its publications of dissociative disorders provide a model for individuals to not only learn about dissociative disorders, but also engage in similar dissociative behaviors. And this theory has been supported by the significant increase in dissociative identity disorder cases after the publication of Sybil, a documentation of a woman's 16 subpersonalities several years back. These mass media productions are not just suggestive to patients. It's been suggested that mass media also influences the ways that clinicians gather information regarding dissociative symptoms of patients. For example, therapists may unconsciously use questions or techniques in session that evoke dissociative types of problems in their patient following exposure to a media source discussing dissociative disorders. And in fact, Elizabeth Loftus's research on eyewitness expert testimony has talked about how repressed memories can inadvertently be essentially implanted in patients if the therapist or interviewer in eyewitness expert testimony type situation where they're recalling a crime having been committed are given leading questions that cause memories to be essentially formed by bits of real information mixed with leading information in there. Because one thing to keep in mind is that memory is essentially reconstructive in nature. It's not. There are people who have photographic memories, but there's a lot of rebuilding in the mix there, and oftentimes the way that we process a memory can add embellishments to it that people really do believe exist. And then finally, on this point, we have psychodynamic theories of dissociative disorders. And the psychodynamic theory of dissociative disorder, as mentioned before, posits that dissociative disorders are caused by an individual's repressed thoughts and feelings related to an unpleasant or traumatic event. And in blocking these thoughts and feelings, an individual is subconsciously protecting themselves from their painful memories. And while a single incidence of repression may explain dissociative amnesia, psychodynamic theorists believe that dissociative identity disorder results from repeated exposure to traumatic experiences such as childhood abuse, neglect, or abandonment. So, according to the psychodynamic perspective, children who experience repeated traumatic events such as physical abuse or parental neglect lack the support and resources to cope with these experiences. To escape from their current situation, children develop different personalities to essentially flee the dangerous situation they are in when they can't physically flee themselves. So while there's limited scientific evidence to support that specific version of the theory, the nature of severe childhood psychological trauma is consistent with this theory, as individuals with dissociative identity disorder have the highest rate of childhood psychological trauma compared to all other psychiatric disorders. So what can be done for these individuals who are suffering from dissociative symptoms? Well, treatment for dissociative disorders is limited for a few reasons. First, with respect to dissociative amnesia, many individuals recover on their own without any intervention. And occasionally treatment is sought out after recovery due to the traumatic nature of the memory loss. But with dissociative identity disorder, the formerly called multiple personality disorder, the ultimate treatment goal for that disorder is the integration of subpersonalities to the point of final fusion. And integration refers to the ongoing process of merging subpersonalities into one personality. Psychoeducation is paramount for integration, as individuals must understand their disorder as well as acknowledge their subpersonalities. And as mentioned previously, many individuals have one-way amnesic relationships with subpersonalities, meaning they're not aware of one another. Therefore, the clinician must first make the individual aware of the various subpersonalities that present across different situations. Now, achieving integration requires several steps. First, the clinician needs to build a relationship and strong rapport with the primary personality. From there, the clinician can begin to encourage communication and coordination between subpersonalities gradually. Making the subpersonalities aware of one another as well as addressing their conflicts is an essential component of integration of subpersonalities and the core of dissociative identity disorder treatment. Once the individual is aware of their personalities, treatment can continue with the goal of fusion. And fusion occurs when two or more alternate identities join. When this happens, there is a complete loss of separateness. Now, depending on the number of subpersonalities, this process can take quite a while. Once all subpersonalities are fused and the individual identifies themselves as one unified self, it is believed that the patient has reached final fusion. Now, it should be noted that final fusion is difficult to obtain. As you can imagine, some patients do not find final fusion a desirable outcome, particularly those with harrowing stories, chronic, severe stressors, advanced age, and comorbid medical and psychiatric disorders, to name a few. For individuals where final fusion is not the treatment goal, the clinician may work towards resolution or sufficient integration and coordination of subpersonalities that allows the individual to function independently. Unfortunately, individuals that do not achieve final fusion are at a greater risk for relapse of symptoms, particularly those with whose dissociative identity disorder appears to stem from traumatic experiences. Once an individual reaches final fusion, ongoing treatment is essential to maintain this status. And in general, treatment focus on social and positive coping skills is the goal. And these skills are particularly helpful for individuals with a history of traumatic events, as it can help them process these events as well as help prevent future relapse. Now, one thing to keep in mind is that there is a movement with among psychotherapists who believe essentially that these subpersonalities are truly separate individuals existing within the self. And so therefore the idea of fusing them is unethical because that would be in essence destroying these other people within the individual. This is a bit of a controversial view. And it is, I think, one of the reasons why the awareness of the different personalities, of the fact that they are, in essence, existing within one individual, is key because it allows you to kind of split the difference. It allows them to kind of collectively make a decision as to whether final fusion is something that each personality wants. Because, in essence, the person is a fragmented self that manifests neurobiologically as and psychologically as separate selves. So it becomes a bit of a dicey ethical process, and it is worth noting that the discussions on this are ongoing. Um, Now, when we talk about dissociative amnesia, as previously mentioned, many individuals regain memory without the need for treatment. However, there is a small population that does require additional treatment. Now, there's no evidence-based treatment for dissociative amnesia. Both hypnosis and phasic therapy have been shown to produce some positive effects in patients with dissociative amnesia. Um, and one of the reasons for this may be that one theory of dissociative amnesia is that it is a form of essentially self-hypnosis, and that individuals kind of reflexively hypnotize themselves to forget information or events that are unpleasant. And because of this theory, one type of treatment that has routinely been implemented for individuals with dissociative amnesia is, in fact, hypnosis. And through hypnosis, the clinician can help the individual contain, modulate, and reduce the intensity of the amnesia symptoms, thus allowing them to process the traumatic or unpleasant events underlying the amnesia episode. So, to do this, the clinician will encourage the patient to think of memories just before the amnesic episode as though it was the present time. The clinician will then slowly walk them through the events during the amnesic episode to reorient them to experience these events. This technique is essentially a way to encourage a controlled recall of dissociative memories, something that is particularly helpful when the memories include traumatic experiences. Another form of hypnosis is to use is the use of barbiturates, known as it used to be known as truth serums, to help relax the individual and free their inhibitions. Although not always effective, the theory is that these drugs reduce the anxiety surrounding the unpleasant events enough to allow the individual to recall and process these memories in a safer environment. Now, when we talk about depersonalization and derealization disorder, the symptoms of these disorders generally occur, or this disorder, I should say, generally occur for an extensive period before the individual seeks out treatment. And because of this, there is some evidence to support that the diagnosis alone is effective in reducing symptom intensity, as it also relieves the individual's anxiety surrounding the baffling nature of their symptoms. So, due to the high comorbidity of depersonalization and derealization disorder with anxiety and depression, the goal of treatment is often alleviating these secondary mental health symptoms related to the depersonalization and derealization symptoms. Now, while there's been some evidence to suggest treatment with SSRIs, so antidepressants, modern antidepressants, is effective in improving mood, the evidence for for a combined treatment method of pharmacological, psychopharmacological, and psychological treatments is even more compelling. The psychological treatment of preference, treatment of choice, is cognitive behavioral therapy, as it addresses the negative attributions and appraisals contributing to the depersonalization and derealization symptoms. Now, by challenging these catastrophic attributions in response to stressful situations, the individual can reduce overall anxiety levels, which consequently reduces the depersonalization and derealization symptoms. So this leads into a discussion of anxiety, right? Because what we're talking about with depersonalization and derealization disorder is that there is this kind of response to anxiety that seems to be central to it. And while depersonalization, derealization disorder is not an anxiety disorder, it's a dissociative disorder. With a lot of these disorders, they will have features of one another. And so the categorization system, I should say, is such that we acknowledge that as comorbidity, but it's worth then transitioning to a discussion of anxiety disorders, right? Separate category of disorders that are in general more common than dissociative disorders, right? Versus dissociative episodes, which are quite common. So, the hallmark symptoms of anxiety related disorders are excessive fear and anxiety and related behavioral disturbances. So, how do we distinguish fear from anxiety? Well, the DSM says that fear is an emotional response to a real or perceived imminent threat, which leads to, quote, surges of automatic arousal necessary for fight or flight, thoughts of immediate danger, and escape behaviors. So, anxiety, on the other hand, is the anticipation of a future threat leading to, quote, muscle tension and vigilance in preparation for future danger and cautious or avoidant behaviors. So, there's a distinction there. The anxiety disorders differ from one another in the types of objects or situations that lead to fear, anxiety, or avoidance behavior. Now, for this next section of the lecture, we're going to cover generalized anxiety disorder, specific phobias, agoraphobia, social anxiety disorder, and panic disorder. So, generalized anxiety disorder is characterized by an underlying excessive anxiety and worry related to a wide range of events or activities and lasting for more days than not for at least 6 months. Now, while many individuals experience some degree of worry throughout the day, individuals with generalized anxiety disorder experience worry of greater intensity and for longer periods than the average person. Additionally, they're often unable to control their worry through various coping strategies, which directly interferes with their ability to engage in daily social and occupational tasks. To receive a diagnosis of generalized anxiety disorder, three or more of the following somatic symptoms must be present in adults as well: restlessness, fatigue, difficulty concentrating, irritability, muscle tension, and problem sleeping. So let's discuss a case example of generalized anxiety disorder. Names and a lot of identifying information have been changed to protect the patient, but we have Anna, a 32-year-old freelance graphic designer. And she presented to therapy stating that she has always been a worrier, but that the past year has been especially challenging with her anxiety escalating to a point where it significantly impacts her daily life. She expresses constant worries about various aspects, including her finances, her freelance projects, and health and well being of her parents. She acknowledges that her level of worry is often out of proportion to the actual circumstances, and she describes experiencing persistent senses of dread and being on edge most of the time, even if she acknowledges that her worry is out of proportion. She struggles with uncontrollable worrying, replaying potential negative scenarios repeatedly in her mind. Physically, she reports chronic muscle tension, especially in her neck and shoulders, and frequent headaches. She also experiences difficulty falling and staying asleep, resulting in fatigue and irritability throughout the day, and her concentration is impacted, making it challenging to focus on work and other tasks. Anna's anxiety has significantly interfered with her daily life. She frequently overthinks plans and solutions, hindering her ability to efficiently manage her freelance projects. She finds it hard to relax and enjoy activities, even those she used to find pleasurable. Her fear of making mistakes and fear of failure often leads to procrastination and difficulty initiating tasks. She also avoids situations more frequently due to her anxieties, leading to feelings of isolation and an impact on her relationships. Now, Anna reports that a recent period of financial instability combined with a challenging client project seemed to significantly exacerbate her anxieties, leading to noticeable increases in the severity and frequency of her worrying. So, based on the assessment, Anna meets the criteria for generalized anxiety disorder as evident by excessive and uncontrolled worrying about various events and activities, accompanied by at least three associated symptoms: her restlessness, her fatigue, her muscle tension, her sleep disturbance, her irritability, and her difficulty concentrating, which were present for more days than not for at least 6 months. Because keep in mind, she's been experiencing this for over a year. Now, the treatment plan in the treatment plan, Anna worked with her therapist utilizing cognitive behavioral therapy to challenge her negative thought patterns and develop coping mechanisms to manage her anxiety. The treatment focused on identifying triggers, practicing relaxation techniques like deep breathing and mindfulness, and engaging in gradual exposure to anxiety provoking situations, pairing them with relaxation exercises to disempower them. She also explored techniques like journaling to process her worries and practiced cognitive restructuring to reframe her anxious thoughts into ones that were more realistic and adaptive. Now, Anna was also encouraged to maintain a healthy lifestyle, including regular exercise and adequate sleep, to help manage her symptoms. And if needed, she was offered medication um, in conjunction with therapy as a result of a consultation with a psychiatrist, but she didn't end up utilizing it as her symptoms abated after a prolonged period of treatment. So you can see how this might present in your average run-of-the-mill case and how it might also be very debilitating, but how a process of therapy, especially an empirically supported form of therapy, could be particularly helpful in creating symptom abatement. Now, another anxiety disorder of note is specific phobia. And specific phobia is distinguished by fear or anxiety to an object or a situation. Now, while the amount of fear or anxiety related to the specific object or situation varies among individuals, it also varies related to the proximity of the object or situation. So, when individuals are face to face with their specific phobia, immediate fear is present, and the phobic object or situation is actively avoided or endured. It should also be noted that these fears are excessive, they're irrational, often severely impacting one's daily functioning. The fear, anxiety, or avoidance is persistent, lasting on average at least 6 months. So individuals can experience multiple specific phobias at the same time. In fact, nearly 75% of individuals with specific phobia report a fear of more than one object, and the average individual fears three or more objects or situations. Now, when making a diagnosis of specific phobia, it's important to identify the stimulus. Among the most diagnosed specific phobias are animals, natural environments such as height, storms, water, blood, injection, or injury, such as needles or invasive medical procedures, or situational phobias, such as airplanes, elevators, enclosed spaces. And in terms of gender differences, women predominantly experience animal, natural, environment, and situational specific phobias, while blood injection and injury phobias are experienced by women and men equally. Now, agoraphobia is one version of a specific phobia, and and just to illustrate it here, it's defined as an intense fear or anxiety triggered by two or more of the following. One, using public transportation such as planes, trains, ships, buses, being in large open spaces such as parking lots, bridges, being in enclosed spaces like stores or movie theaters, or being in a crowd or standing in line, or being outside of the home alone. The individual fears or avoids these situations because they believe something terrible may occur, and due to concern over not being able to escape uh, or help not being available to them. Now, active avoidance of the situation occurs and can be behavioral, such as changing one's daily routine or using a delivery service to avoid entering a restaurant, or cognitive strategy, such as using distraction to bear with an agoraphobic situation. The avoidance can result in the person being homebound, and the fear or anxiety has to be out of proportion to the actual danger that they pose and has to be present for at least 6 months. So let's have another case example, shall we? So here we have Sasha, age 32, a female marketing manager, and her presenting problem is an intense fear of heights, so acrophobia. So this is different from agoraphobia, but it is an example of specific phobia. So Sasha has experienced a fear of heights for as long as she can remember. While she initially managed to avoid situations involving heights, her phobia has become increasingly debilitating, impacting her career and personal life. Sasha declined a promotion due to fear that she would need to travel by plane, which often involves being in or being in situations which often involve being in tall buildings or at high altitudes. She avoided visiting her elderly parents on the fifth floor of their apartment building and relied on her husband to transport groceries and supplies to their home to avoid being in elevated situations. Everyday tasks like going to the grocery store or walking around town became challenging to her due to her fear of tall buildings, bridges, and other objects that triggered her anxiety. And Sasha had sought help from a therapist 2 years prior to presenting to therapy again, but found the initial cognitive behavioral therapy approach of identifying and challenging negative thoughts related to insights unhelpful, as she still experienced intense anxiety during exposure exercises. Um, she otherwise, when she presented to her next round of therapy, she appeared well groomed and cooperative, but still reported feeling on edge, especially when contemplating situations involving heights. Her thought processes were logical, but she exhibited a pervasive preoccupation with heights and safety that was illogical. And she reported no hallucinations or delusions, and her mood was just generally anxious. So she was diagnosed with specific phobia, situational type, acrophobia, as per the DSM-5 criteria. She was prescribed exposure therapy, which gradually exposed Sasha to situations involving heights, starting with less anxiety provoking stimuli and progressively increasing the level of fear. There was also cognitive restructuring that was prescribed to help Sasha challenge her automatic negative thoughts and replace them with more adaptive and realistic thoughts about heights. And relaxation techniques were provided to teach Sasha breathing exercises and mindfulness techniques to manage anxiety symptoms when going through exposure therapy, which was probably what made it a little bit more bearable than her previous round of CBT. She also engaged with her husband and parents in the treatment process to create a supportive environment and encourage her progress. And her prognosis was good. With consistent effort and continued therapy, she improved significantly. Her anxiety symptoms continued to diminish throughout therapy, allowing her to participate in activities and situations involving heights without experiencing panic or avoidance. And she was able to gain a greater control over her thoughts and emotions, leading to an improved sense of well being and enhanced quality of life. Um, so there's also social anxiety disorder. And in the interest of time, we're going to skip the case example here. But, for social anxiety disorder, the anxiety or fear relates to social situations, particularly those in which an individual can be evaluated by others. And more specifically, the individual is worried that they will be judged negatively and viewed as stupid, anxious, crazy, boring, or unlikable, to name a few. Some individuals report feeling concerned that their anxiety symptoms will be obvious to others, like blushing or stuttering or sweating or trembling. These fears really severely limit an individual's behavior in social settings and have to have occurred for at least 6 months or more. We also have panic disorder. And panic disorder consists of a series of recurrent, unexpected panic attacks, coupled with the fear of future panic attacks. Now, a panic attack, what is it? A panic attack is defined as a sudden or abrupt surge of fear or impending doom, along with at least four physical or cognitive symptoms. Now, physical symptoms include heart palpitations, sweating, trembling, shaking, or shortness of breath. Um, they can also include feeling as though somebody's being choked, or that they might experience chest pain, nausea, dizziness, chills or heat sensations, numbness or tingling. Cognitive symptoms may consist of feelings of derealization or unreality, or depersonalization, feelings of being detached from oneself, the fear of losing control or going crazy, or the fear of dying. Now, while the symptoms generally peak within a few minutes, it seems much longer for the individual experiencing the panic attack. Now, there are two key components of panic disorder. The attacks are unexpected. That's number one, meaning that there's nothing that triggers them. And they're reoccurrent, meaning that they occur multiple times. And because these panic attacks occur frequently and are primarily out of the blue, they can cause significant worry or anxiety in individuals as they are unsure of when the next attack will happen. So, in contrast to unexpected, there are also expected panic attacks, or those that have an obvious trigger. And the DSM-5-TR states that the presence of an expected panic attack does not rule out the diagnosis of panic disorder, as about half of individuals diagnosed with the disorder in the US and Europe have both types of panic attacks. Now, in some individuals, significant behavioral challenges, such as fear of leaving their home or attending large events, occur as the individual is fearful an attack will happen in one of these situations, causing embarrassment. Additionally, individuals report worry that others will think that they're going crazy or losing control if they were observed in the middle of a panic attack. Now, occasionally, an additional diagnosis of agoraphobia is given to an individual with panic disorder if their behaviors meet the diagnostic criteria for that disorder as well. So, the frequency and intensity of these panic attacks vary wildly among individuals. So, some people report panic attacks occurring once a week for months on end. Others report more frequent attacks multiple times a day, but then experience weeks or months without any attacks. So, the intensity of symptoms also varies among individuals, with some patients experiencing four or more symptoms. So, full symptoms, or less than four, which is limited symptoms. Furthermore, individuals report variability within their panic attack symptoms, with some panic attacks presenting with more symptoms than others. Now, to be diagnosed with panic disorder, the individual must present with more than one unexpected full symptom panic attack. So, now let's start talking about the epidemiology of these various anxiety disorders, right? How often do they occur? Because people talk about anxiety left and right in pop psychology and in our culture. Well, when we talk about generalized anxiety disorder, the 12-month prevalence for generalized anxiety disorder in the US is estimated to be 2.9% of the adult general population, while the mean 12-month prevalence in around the world is about 1.3%, with a range of about 0.2% to 4.3%. So it varies pretty significantly. The disorder does occur more frequently in women and adolescent girls and those of European descent and those living in high income countries, which is kind of an interesting little tidbit of information there. With specific phobia, the prevalence rate is about 8 to 12%. It's pretty significant in the US and about 6% in European countries. So pretty surprising there, right? That it's so much more prevalent in the US than Europe. It makes one wonder why that might be the case. There's a 2-to-1 ratio of females to males diagnosed with specific phobia, and the prevalence rates are lower in older individuals and those from Asia, Africa, and Latin America. Now, with agoraphobia, the prevalence rate worldwide for adolescents and adults is between 1 and 1.7%. As with other anxiety disorders, women are twice as likely to be diagnosed with it. And older adults in the US, age 65 and up, have a 12-month prevalence of 0.4%. And for older adults 55 and up in Europe and North America, the prevalence is 0.5%. What about social anxiety disorder? Well, the overall prevalence rate of social anxiety disorder is significantly higher in the US than other countries, and is with an estimated 7% of the US population diagnosed with social anxiety disorder compared to 0.5 to 2% worldwide, with the median prevalence in Europe being about 2.3%. A decrease in the diagnosis of social anxiety disorder among older individuals age 65 and older has been found. And regarding gender, there's a higher diagnosis rate in females than in males. Now, this gender discrepancy is greater among adolescents and young adults. Finally, non-Hispanic whites in the US have a higher prevalence rate than Asians, Latin Americans, African Americans, and uh, Caribbean Black descent individuals as well. Um, Finally, we also have panic disorder. And the 12-month prevalence for panic disorder in the US is between 2 to 3% of adults and adolescents, and those from several European countries. The higher rates of panic disorder are found in American Indians and non-Latinx whites. So females are more commonly diagnosed than males with a 2-to-1 diagnosis rate, and prevalence declines from about 1.2% in older adults than 55 to uh, older adults than 55 years old, I should say, to 0.7% in adults age 64 and up. So, what about comorbidity? Well, with generalized anxiety disorder, there's high comorbidity between GAD and other anxiety-related disorders, such as depressive disorders, unipolar depressive disorders, non-bipolar depressive disorders is what I'm referring to. So comorbidity also exists with substance use, neurodevelopmental, neurocognitive, psychotic, and conduct disorders, which is uh, or actually, I should say, I should correct myself there. Comorbidity with substance use, neurodevelopmental, neurocognitive, psychotic, and conduct disorders is less common for those afflicted with generalized anxiety disorder. Generalized anxiety disorder is also associated with higher levels of suicidal ideation, so thoughts of suicide, and suicidal behavior, so actions. And psychological autopsy studies reveal it's the most frequent anxiety disorder diagnosed in suicides, which is um, quite striking. With specific phobia, other anxiety disorders, depressive and bipolar disorders, substance-related disorders, and somatic symptom disorders are typically comorbid. Additionally, personality disorders, in particular dependent personality disorder, are comorbid as well. Specific phobias are associated with the transition from suicidal ideation to suicide attempt. With agoraphobia, as with other anxiety disorders, common comorbid mental health disorders include other anxiety disorders and depressive disorders. Agoraphobia is also comorbid with PTSD and alcohol use disorder. For those with comorbid major depressive disorder, the agoraphobia is more treatment resistant, unfortunately, compared to those with agoraphobia alone. Now, about 15% of patients diagnosed with agoraphobia report suicidal thoughts or behavior. And among the most common comorbid diagnoses with a social anxiety disorder are other anxiety-related disorders like major depressive disorder and substance-related disorder. The high comorbidity rate among anxiety-related disorders and substance-related disorders is likely connected to the efforts of self-medicating to deal with social fears. For example, an individual with social anxiety disorder may consume more alcohol in social settings in an effort to alleviate the anxiety of the social situation. The comorbidity with major depressive disorder may be due to the chronic social isolation associated with social anxiety disorder. And comorbidity has also been found with body dysmorphic disorder and avoidant personality disorder. Finally, we also have panic disorder. And panic disorder rarely occurs in isolation. So 80% of individuals report symptoms of another anxiety disorder or major depressive disorder or bipolar 1 or 2, and possibly mild alcohol use disorder. Some individuals diagnosed with panic disorder also develop a substance-related disorder, likely as an attempt to treat their anxiety with alcohol or other substances. So about 25% of patients report suicidal thoughts, and the disorder may increase the risk for future suicidal behaviors, but not deaths. So they may engage in suicide attempts, but not necessarily to the point where they are successful in those attempts. Now, unlike some of the other anxiety disorders, there's a high comorbidity with general medical symptoms. More specifically, individuals with panic disorder are more likely to report somatic symptoms such as dizziness, cardiac arrhythmias, COPD, asthma, irritable bowel syndrome, and hyperthyroidism. But the relationship between panic symptoms and these conditions is, at least at this point, unclear. So, what about the etiology? Where does all this come from? Well, like with so many of these disorders, there's theorized to be a genetic influence. And while genetics have been known to contribute to the presentation of anxiety symptoms, the interaction between genetics and stressful environmental influences to account for more anxiety disorders appears to account for more anxiety disorders than genetics alone. So the quest to identify specific genes that may predispose individuals to develop anxiety disorders has led researchers to the serotonin transporter gene 5-HTTLPR. And so mutation on this gene is related to a reduction in serotonin activity and an increase in anxiety-related personality traits. Now, from a biological or neurobiological perspective, researchers have identified several brain structures and pathways that are likely to be responsible for anxiety responses. And among these structures is the amygdala, the area of the brain that is responsible for storing memories related to emotional events. So, when presented with a fearful situation, the amygdala initiates a reaction to the body for a response. First, the amygdala triggers the hypothalamic pituitary adrenal axis, the HPA axis, to prepare for immediate action, either fight or flight. The second pathway is activated by the fear stimulus itself by sending sensory signals to the hippocampus and prefrontal cortex to determine if the threat is real or imagined. If it's determined that no threat is present, the amygdala sends a calming response to the HPA axis, thus reducing the level of fear. But if a threat is present, the amygdala is activated, producing a fear response. Specific to panic disorder is the implication of the locus coeruleus, the brain structure that serves as an on-off switch for norepinephrine neurotransmitters. And it's believed that increased activation of the locus coeruleus it results in panic-like symptoms. Therefore, individuals with panic disorder may have a hyperactive locus coeruleus, leaving them more susceptible to experience more intense and frequent physiological arousal than the general population. This theory is supported by studies in which individuals experienced increased panic symptoms following the injection of norepinephrine, which is kind of an interesting result there. Unfortunately, norepinephrine and the locus coeruleus fail to fully explain the development of panic disorder, as a treatment would be much easier if only norepinephrine was implicated. Therefore, researchers argue that a more complex neuropathway is likely responsible for panic disorder. Uh, More specifically, the corticostriatal thalamocortical or CSTC circuit is known as the fear specific circuit and is theorized as a major contributor to panic symptoms. So, when an individual is presented with a frightening object or situation, the amygdala is activated, sending a fear response to the anterior cingulate cortex and the orbitofrontal cortex. Additionally, a projection from the amygdala to the hypothalamus activates an endocrine system response to fear, releasing adrenaline and cortisol to help prepare the body to fight for a fight or flight response. Now, this complex pathway supports the theory that panic disorder is mediated by several neuroanatomical structures and their associated neurotransmitters. What about the psychological viewpoint? Well, from the cognitive perspective on the development of anxiety-related disorders, it centers around the dysfunction of thought patterns. So, as seen in depression, maladaptive assumptions are routinely observed in individuals with anxiety-related disorders, and they often engage in interpreting events as dangerous or overreacting to potentially stressful events, which contributes to an overall heightened anxiety level. These negative appraisals, in combination with a biological predisposition to anxiety, likely contribute to the development of anxiety symptoms. And sensitivity to physiological arousal not only contributes to anxiety disorders in general, but also for panic disorder, where the individual experiences various physiological sensations and misinterprets them as catastrophic. One explanation for this theory is that individuals with panic disorder are more susceptible to more frequent intensive physiological symptoms than the general public. Others argue that these individuals have had more trauma-related experiences in the past and are therefore quicker to misevaluate symptoms as a potential threat. So the misevaluation of symptoms as impending disasters likely maintains the symptoms as the cognitive misinterpretation to physiological arousal creates a negative feedback loop, leading to more physiological changes. Now, social anxiety is primarily explained by cognitive theorists, and individuals with social anxiety disorder tend to hold unattainable or extremely high social beliefs and expectations. They also often engage in preconceived maladaptive assumptions that they will behave incompetently in social situations and that their behaviors will lead to terrible consequences. So, because of these beliefs, they anticipate social disasters will occur. And so they end up avoiding social encounters or limiting them to close friends and family in an effort to prevent the disaster, or at least reduce the likelihood. Unfortunately, these cognitive appraisals are not only isolated to before and during the event. And individuals with social anxiety disorder will also evaluate the social event after it's taken place, often obsessively reviewing the details and overestimating the negative social performance, which reinforces future avoidance of social situations and future social anxiety. Um, there's also a behavioral component. So, the behavioral explanation for the development of anxiety disorders is mainly reserved for phobias. Um, Both specific and social phobia. More precisely, behavioral theorists focus on respondent conditioning when two events occur close together and become strongly associated with each other despite their lack of a causal relationship. So the Little Albert experiment would be a perfect example of this, where, pairing the loud, fear-inducing noise with a white rat created a phobia to white fluffy things, to the white rat. There's also, from a psychological perspective, modeling, another behavioral explanation of the development of specific phobias, where an individual acquires a fear through observation, imitation of an irrational fear that another might have. Um, there's also sociocultural elements, so seeing how prominent the biological and psychological constructs are in explaining the development of anxiety-related disorders. It's also important to understand social constructs that contribute to and maintain anxiety disorders. So, while characteristics such as living in poverty or experiencing significant daily stressors and increased exposure to traumatic events are all identified as single contributors to anxiety disorders, additional sociocultural influences such as gender and discrimination have also received considerable attention, mainly due to the epidemiological nature of the disorder. Gender has largely been researched within anxiety disorders due to the consistent discrepancy in the diagnosis rate between men and women. And as previously discussed, women are routinely diagnosed with anxiety disorders more often than men. So, how do we treat all of this? Well, when it comes to generalized anxiety disorder, we have psychopharmacology, benzodiazepines. They're a class of sedative hypnotic drugs. And they were originally replaced barbiturates in leading anti-anxiety medication due to their less addictive nature, but they still are addictive, and yet they're equally effective to calm individuals at low dosages. Unfortunately, as more research was done on benzos, serious side effects as well as physical dependence in large doses has routinely been documented. And so, due to these negative effects, selective serotonin reuptake inhibitors, SSRIs, and serotonin norepinephrine reuptake inhibitors, SNRIs, are generally considered to be the first line medications for those with generalized anxiety disorders, with findings indicating a 30 to 50% positive response rate to these psychopharmacological interventions. Unfortunately, none of these medications continue to provide any benefit once they're stopped. Therefore, the effective treatment options such as CBT, cognitive behavioral therapy, relaxation training, biofeedback, are often encouraged before the use of pharmacological interventions. There's also rational emotive therapy developed by Albert Ellis, which was reviewed in previous lectures, um, as one of the first forms of CBT that existed, that helps individuals to kind of reframe their maladaptive or self-defeating thoughts. There's also biofeedback, which provides visual representations of a patient's physiological arousal, and it allows them to utilize a computer that provides continuous information about their physiological states while engaging in relaxation exercises to help them to engage in effective relaxation responses. We also have exposure treatments, exposure therapies with systematic desensitization and flooding, as well as modeling, which can be helpful from a behavioral therapeutic angle as well. Now, when talking about anxiety disorders, it's one of the fundamental elements of another disorder is anxiety, and that is somatic symptom disorder. So, for this section of the lecture, we're going to continue to discuss matters related to anxiety, but we're going to talk about somatic symptom disorder or disorders as a manifestation of anxiety and a manifestation of real physiological symptoms that can be related to that anxiety. So this is going to include the clinical presentation, epidemiology, comorbidity, etiology, and treatment options for somatic symptom disorders, illness anxiety disorders, and functional neurological symptom or conversion disorders, as well as factitious disorders. We're also going to discuss psychological factors affecting other medical conditions in relation to their clinical presentation, their diagnostic criteria, and common types of psychophysiological disorders and treatment. Now, psychophysiological or psychological disorders that feature somatic symptoms are often really challenging to diagnose due to the internalizing nature of the disorder. What does that mean? Well, it means there's really no way for a clinician to measure the somatic symptom. And further, the somatic symptoms could take on many forms. For example, the individual may be faking the physical symptoms. They may be imagining the symptoms or exaggerating the symptoms, or they could be real and triggered by external factors such as stress or other psychological disorders. The symptoms may also be a part of a real medical illness or disorder, and therefore the symptoms should be treated medically. But all the disorders within this type share a common feature, the presence of somatic symptoms and or illness anxiety associated with significant distress or impairment. So oftentimes individuals with a somatic disorder will present to their primary care physician with their physical complaints. Occasionally, they'll be referred to a clinical psychologist after an extensive medical evaluation concludes that a medical diagnosis cannot explain their current symptoms. And as you're going to see, despite their similarities, there are key features that distinguish these disorders in this class from one another. So individuals with somatic symptom disorder often present with multiple somatic symptoms at once. These symptoms are significant enough to impact their daily functioning, such as preventing them from attending school or work or family obligations. The symptoms can be localized, they can be in one spot, or diffused throughout the entire body. And they can be specific or non-specific, such as fatigue. Um, Individuals with somatic symptom disorders often report excessive thoughts, feelings or behaviors surrounding their somatic symptoms. For example, individuals with somatic symptom disorder may spend an excessive amount of time or energy evaluating their symptoms, as well as the potential seriousness of their symptoms. A lack of medical explanation is not needed for a diagnosis of somatic symptom disorder, as it's assumed that the individual's suffering is actually authentic. So, somatic symptom disorder is often diagnosed when another medical condition is present, as these two diagnoses are not mutually exclusive. Now, somatic symptom disorder patients generally present with difficulty worrying about their illness. Their interpretation of symptoms is often viewed as threatening, harmful, or troublesome. And because of their negative appraisals, they fear that their medical status is more serious than it typically is, and high levels of distress are often reported. Oftentimes, these patients will shop at different physicians' offices, shop in quotation marks, it should be, um, eh, to confirm the seriousness of their symptoms. So they'll be looking for somebody to validate their experience. And if a medical practitioner doesn't validate the seriousness of their symptoms, they will disregard that practitioner and go on to somebody else. Now, there are different versions of this. There's illness anxiety disorder, which was previously known as hypochondriasis, and it involves an excessive preoccupation with having or acquiring a serious medical illness. The key distinction between illness anxiety disorder and somatic symptom disorder is that an individual with illness anxiety disorder does not typically present with any somatic symptoms. Occasionally, an illness or an individual, I should say, will present with a somatic symptom. However, the intensity of the symptom is usually mild and it doesn't drive the anxiety. Acquiring a serious illness drives the concerns, and they will even avoid visiting a sick relative or friend for fear of jeopardizing their own health. Now, individuals with illness anxiety disorder are generally cleared medically, so they don't have a co-occurring medical illness. That's one important distinction with somatic symptom disorder. However, some individuals are diagnosed with a medical illness. In this case, their anxiety surrounding the severity of their disorder is excessive or disproportionate to their actual medical diagnosis. So, while an individual's concern for an illness may be due to maybe due to a physical sign or a sensation, most individuals' concerns are derived not from a physical complaint, but an actual anxiety to a suspected medical disorder. And this excessive worry often expands to generalized anxiety regarding one's own health and disease. Now, unfortunately, this anxiety it does not decrease even after reassurance from a medical provider or a negative test result, even when provided by multiple physicians' diagnostic tests. So, as one can imagine, the preoccupation and anxiety associated with attaining a medical illness severely impacts daily functioning. And the individual will often spend copious amounts of time scanning and analyzing their body for clues of potential ailments. And additionally, an excessive amount of time is often spent on internet searches related to symptoms and rare illnesses. Now, illness becomes a central feature of the person's identity and self image, although extreme, some cases of invalidism have been reported due to illness anxiety disorder. So, how do we make sense of these disorders when we talk about the distinction between a somatic symptom disorder and illness anxiety disorder? Well, when we look at the relationship for somatic symptom disorder, the patient presents with multiple somatic symptoms at one time that are significant enough to impact their daily functioning. And for illness anxiety disorder, the patient does not typically present with any somatic symptoms, but if they do, the symptoms are just mild in intensity. We also have functional neurological symptom disorder within this broader category, which used to be known as, and still to a certain extent is known as, conversion disorder. And this occurs when an individual presents with one or more symptoms of altered voluntary motor or sensory function. So common motor symptoms include weakness or paralysis, abnormal movements like tremors, and gait abnormalities like limping. There's also sensory symptoms, which include altered or reduced or absent skin sensations, vision, or hearing. Less commonly seen are epileptic seizures and episodes of unresponsiveness or resembling fainting or coma. The disorder was called conversion disorder in prior versions of the DSM and in the psychiatric literature. And the term conversion originated in the psychoanalytic community and psychoanalytic theory, which proposes that unconscious psychic conflict is converted into physical symptoms. Now, the most challenging aspect of functional neurological symptom disorder is the complex relationship with a medical evaluation. Now, while a diagnosis of conversion disorder requires that the symptoms not be explained by a neurological disease, just because a medical provider fails to provide evidence that it is not a specific medical disorder isn't sufficient for diagnosis. Therefore, there must be evidence of an incompatibility of the medical disorder and the symptoms. For example, an individual experiencing a seizure would require a normal simultaneous EEG or electroencephalogram indicating that there's actually not a seizure or epileptic activity taking place during what was previously thought of as an epileptic seizure or looked like an epileptic seizure to the untrained eye. Um, Now, factitious disorder differs from the three previously discussed somatic disorders in that there's a deliberate falsification of medical or psychological symptoms imposed on oneself or on another with the overall intention of deception. So, while a medical condition may be present, the severity of impairment related to the medical condition is more excessive due to the individual's need to deceive those around them. So even more alarming is that this disorder is not only observed in individuals leading the deception, it can also be present in another individual, often a child or an individual with a compromised mental status who's not aware of the deception behind their illness. So, what does this look like? Well, some examples of factitious disorder behaviors include, but are not limited to, altering urine or blood tests, falsifying medical records, ingesting substances that would indicate abnormal laboratory results, physically injuring oneself or another person, inducing illnesses by injecting or ingesting harmful substances or giving those substances to another person to make them appear sick. Although most individuals with factitious disorder seek treatment from healthcare professionals, some choose to mislead community members either in person or online about their illness or injury. Now, while it's unclear why an individual would want to fake their own or someone else's physical illness, there is some evidence suggesting that factors such as depression, lack of parental support during childhood, or an excessive need for social support may contribute to this disorder. So, what are the prevalence rates here? Well, for somatic symptom disorder, um, uh, they're often difficult to determine just kind of across the board for any disorder within this broad category. However, overall estimates of somatic symptom disorder are around 4 to 6%. There's a trend that females report more somatic symptoms than males. So more females are diagnosed with somatic symptom disorder than males. Um, and looking at illness anxiety disorder and seeing as it's a newer diagnosis replacing hypochondriasis, prevalence rates are largely based on the uh, previous name of the disorder, hypochondriasis. So previous findings suggest that illness anxiety disorder occurs in about 1.3 to 10% of the general population and is equal among males and females. Now, prevalence rates of factitious disorder are largely unknown, likely due to the use of deception in individuals diagnosed with the disorder. Additionally, healthcare professionals infrequently record the diagnosis, even in recognized cases. And like the other somatic symptom disorders, the prevalence of functional neurological symptom disorder is unknown, even though transient functional neurological symptoms are common. And in the US and Northern Europe, research shows that the incidence of individual persistent functional neurological symptoms is around 4 to 12 out of every 100,000 people annually. Now, given that half of psychiatric patients also have a medical disorder, 35% have an undiagnosed medical condition, and approximately 20% reported medical problems caused their mental condition. It should not come as a surprise that somatic symptom disorders, or somatic disorders, I should say, in general, have high comorbidity with other psychological disorders. More specifically, anxiety and depressive disorders are among the most commonly co-diagnosed disorders for somatic disorders. And while there's not a lot of information regarding specific comorbidities among somatic symptom and related disorders, there is some evidence to suggest that those with illness anxiety disorder are at risk of developing OCD and personality disorders. Now, similarly, personality disorders are more common in individuals with functional neurological symptom disorder than the general public. And somatic symptom disorder is also comorbid with PTSD and OCD. No comorbidity information is given for factitious disorder in the DSM, unfortunately. There is also comorbidity between somatic disorders and other physical disorders classified as central sensitivity syndromes, CSSs, due to their common central sensitization symptoms, yet medically unexplained symptoms. And disorders included in this group are fibromyalgia, irritable bowel syndrome, and chronic fatigue syndrome. And comorbidity rates are estimated at 60% for these functional syndromes and somatic pain disorder. So, what's the etiology here? How does this come to be? Well, psychodynamic theory argues that somatic symptoms present as a response against unconscious emotional issues. Two factors initiate and maintain somatic symptoms: the primary gain and the secondary gain. Primary gains produce internal motivators, whereas secondary gains produce external motivators. So when you relate this to somatic disorders, the primary gain, according to psychodynamic theorists, provides protection from the anxiety or the emotional symptoms and or conflicts. And the need for protection is expressed via physical symptoms such as pain, headache, etc. The secondary gain, the external experiences from the physical symptoms that maintain these physical symptoms can range from attention and sympathy to getting off of work or obtaining financial assistance or a psychiatric disability, to name a few. Now, cognitive theorists often believe that somatic disorders are the result of negative beliefs or exaggerated fears of physiological sensations. And individuals with somatic related disorders may have a heightened sensitivity to bodily sensations. And this sensitivity, combined with their maladaptive thought patterns, may lead individuals to overanalyze and interpret their physiological symptoms in a negative light. For example, an individual with a headache may catastrophize the symptoms and believe that their headache is the direct result of a brain tumor, as opposed to stress and or other inoculate reasons. Um, and whether the medical provider does not confirm this diagnosis or not, or does not confirm the diagnosis, the individual may then catastrophize even further, believing they have an extremely rare disorder that requires an evaluation from a specialist. Um, Now, keeping true to the behavioral approach to psychological disorders, behaviorists propose that somatic disorders are developed and maintained by reinforcement and punishment. More specifically, individuals experiencing significant somatic symptoms are often rewarded by gaining attention from other people. And these rewards may also extend to more significant factors, such as receiving disability payments. Um, Now, while the behavioral theory of somatic disorders appears to be like the psychodynamic theory of secondary gains, there's a clear distinction between the two. Behaviorists view these gains as the primary reason for the development and maintenance of the disorder, whereas psychodynamic theorists view these gains as secondary, only after the underlying conflicts create the disorder. And finally, sociocultural causes are theorized to be related to familial influence and cultural maintenance of the presentation of symptoms. For example, Westerners tend to have a viewpoint that psychological symptoms sometimes influence somatic symptoms, whereas Easterners focus more heavily on the mind-body, mind-body relationship and how psychological and somatic symptoms interact with one another. And these different cultural beliefs are routinely seen in research where Asian populations are more likely to report the physical symptoms related to stress than the cognitive or emotional problems than many in the United States or Europe tend to present. So, how do we treat this? Well, treatment for these disorders is often difficult as individuals see their problems as completely medical and therefore do not think that psychological intervention is necessary. Once an individual does not find relief from their symptoms after meeting with several different physicians, they often do willingly engage in psychotherapy, psychopharmacology, or both. And among the most effective treatment approaches is the biopsychosocial model of treatment. And this approach considers the various biological, psychological, and social factors that influence the illness and presenting symptoms. This treatment is often achieved through physicians, psychiatrists, and psychologists interdisciplinarily coordinating their treatment responses, and it involves a higher level of care as the multiple disciplines interact with one another and identify a common treatment goal. And this approach, although more difficult to find, particularly in more rural settings, is presumed to be more effective due to the integration of healthcare providers and their ability to work together to treat the patient uniformly. Now, there are psychological factors affecting other medical conditions, and psychological factors here it has a primary focus on the physical disorder and not the mental disorder. And the most common types of psychophysiological disorders include headaches or migraines and tension, muscle tension, for example, or gastrointestinal difficulties such as IBS or ulcers, insomnia, coronary heart disease or coronary artery disease, and hypertension. And common treatments for these other medical conditions includes relaxation training, biofeedback, hypnosis, traditional CBT treatments, and group therapy as well. Well, that does it for this lecture. I hope you found it interesting. We covered a lot of ground. Be sure to look to the discussion question for this week, and I will look forward to reading your responses as always. Take good care.